Hello and good morning, good evening, good afternoon. I'm J. Stephen Morrison. I'm Senior Vice President here at the Center for Strategic and International Studies, CSIS, based in Washington, D.C. Today is the 9th episode of the CSIS video broadcast series, Gaza, the Human Toll. It's a product of the CSIS Bipartisan Alliance for Global Health Security in partnership with our colleagues here at CSIS at the Humanitarian Agenda Program and the Middle East Program. I want to offer special thanks today to the many colleagues and friends who've supported us. As we'll see, today we're going to introduce a lead-in video. I'll say that a bit more about that in a moment. We're particularly indebted to Shams Odeh, Justin Kinney, and Paul Franz for our ability to pull this film together, shot inside Gaza just recently, in the recent days. I want to also offer special thanks to Sophia Hirschfield, my colleague in the Alliance, for coordinating all of the aspects of this production, to Eric Raditsky and Chi Yu on our famous production team here. I want to also offer thanks to Todd Bernhardt from the International Medical Corps. As we'll see in a moment, we will be hearing from Dr. Zawar Ali, who is the team lead in Cairo and the medical advisor for the IMC field hospital. He works with the International Medical Corps, went into Rafah January 1st to set up the field hospital. We'll be hearing much more from him. The field hospital figures in the video that we're going to show you to lead off this hour. Dr. Zawar Ali is a physician and senior specialist with International Medical Corps in Pakistan. Went in January 1st, the field hospital became operational 3 days later. He stayed until the early part of February and will be returning again from Cairo overseas, the resupply and coordination and operations of that very important field hospital in Rafah. Our second keynote guest is a friend who's appeared and been very generous to us in earlier episodes, and that is Rick Pieperkorn. He joined in March 2021 when he was appointed as the WHO representative in WHO's Office for the West Bank and Gaza. He's the representative for occupied Palestinian territory. He's appeared on several earlier episodes of this series, and we're very grateful that he's making the time. Obviously, this remains a fraught period. Looming over every conversation is the threat of the siege of Rafah. We have senior Israeli officials here this week for discussions around that and what that might mean and how to think about the looming humanitarian catastrophe. 1.5 million displaced in Rafah. We have increased discussions around the specter of famine and mass starvation in Gaza, concentrated in the worst forms in northern Gaza, but as we'll hear, malnutrition, severe malnutrition affecting larger populations across the territory, and also fear of infectious epidemic diseases and rising excess mortality. Along with the efforts still underway to find some kind of peace accord that would bring a pause to the fighting and to easing of the humanitarian situation and release of hostages, prisoners, and detainees. Today we have a 4.5-minute video that we produced from within Gaza. We're going to go straight to that video, watch that, and then immediately afterwards we will hear from Dr. Ali, followed by Dr. Pieperkorn. So if we could tee up that film right now, thank you.
أخي الكريم، منذ بداية هذا العدوان لا يوجد حماية للطواقم الطبية في قطاع غزة، ويتم استهداف طواقمنا الطبية لدينا في القطاع الصحي. نحن الآن في اليوم 165 على التوالي، عدم وجود كهرباء، عدم وجود مياه صالحة للشرب، عدم وجود مواد غذائية. حتى نحن في هذا المشفى لا نستطيع أن نقدم وجبة غذائية لأي مريض في هذا المستشفى بسبب عدم وجود مواد غذائية. وبالنسبة للمساعدات التي تصل إلى هذا المستشفى لا يلبي احتياجات هذا المستشفى سوى 3%.
يعني احنا بنقول دائما الحمد لله انه في مؤسسات زي هذه فتحت مستشفى انه يستقبل المرضى المزمنين والطارئين.
في الهلال قاعد الهلال الأحمر، فكان في طخ في جنود على العمال بزر الهلال، كان طخ 3 على باب الهلال، فطلعت من الهلال بدي أدخل واحد. فترة ما طلعت أنا دنقت بدي أشيل شهيد، مع لفتة إيدي أكلت طلق إيدي طلق متفجر.
الوضع الصحي في قطاع غزة في الوضع الحالي هو سيء ويزداد سوءا يوما بعد يوم.
يعني احنا شايفين ايش بالنسبة احنا بنشتغل يعني بنحفر الصخر زي ما بنقول. التحاليل غير موجودة، الأدوية شحيحة جدا، الوضع الصحي في قطاع غزة كارثي للغاية.
Thank you to the International Medical Corps for its support in pulling this video together. Thank you, Dr. Ali, for being with us and for your leadership role in establishing this field hospital and your continued oversight and integral role in making it all happen. Over to you, Dr. Ali. Please share with us some of your thoughts around this operation and the broader picture.
Thank you, Stephen. Thank you for having me on this podcast, and thank you for featuring our hospital here. So I'm working as the medical advisor for this field hospital in Gaza, and I initially went in on the 1st of January to help set up the hospital, to help set up the clinical team and the clinical operations inside the hospital. But the journey starts before that. In October, we realized that we needed to provide direct services, healthcare services in Gaza. We have been in Gaza since 2008, but mostly worked through partners. But as we heard and we found out that health infrastructure is being damaged, we understood that there is need to augment the health infrastructure through field hospitals. And we started planning for this. It was a difficult logistic operation, but we were able to get in our supplies and our infrastructure for the field hospital in Gaza by the end of December. We also were recruiting people to manage the clinical operations of Gaza. We had a big international team, which was roughly around 40 international doctors and nurses and midwives. And we hired around 160 national staff, the first phase was setting up the hospital, setting up the tents, the infrastructure for it, managing the clinical flow of the patients. We started off as an outpatient and an ER, which is called the EMT1. And then after starting those outpatient consultations plus ER, we moved to setting up the inpatient area of the hospital. Our outpatient consultation started on the 4th of January, and by 16th of January, we had started inpatient and surgical plus sexual and reproductive health services inside the hospital. These were augmented by nutrition, child protection, gender-based violence services as well in the hospital. And after that, this was followed by 2 phases of extension, where we expanded the hospital from 50 beds to 140 beds. We were and still are facing difficulties with supplies, and one of my roles as a medical advisor is to focus on that here in Cairo. The hospital primary function of the hospital is to provide sexual and reproductive health services to IDPs living in Rafah. As you know, a lot of people from the north have moved into Rafah. It's a small border town that now hosts more than 1 million IDPs. So our primary focus was on sexual and reproductive health services as well as trauma care. Our field hospital is located at the border between Khan Yunis and Rafah, and we see a lot of trauma coming into our hospital. Just to cater to this trauma, we have 2 OTs set up inside the field hospital. We are also providing primary health care. We're providing physical rehabilitation, comprehensive emergency obstetric and newborn care, nutrition support, mental health and child protection services, and water and sanitation and hygiene services as well. We have an intensive care unit, a fully stocked pharmacy, radiology department, which has X-ray and ultrasound services, and we run a fully functional lab as well as blood transfusion services in the hospital. Now, talking about the constraints and the nature of injuries that we are seeing. Initially, when we set up the hospital, we had around 200 outpatient consultations per day, but because of the needs on ground, this has expanded to 600 patients in our outpatient consultation areas every day. Our outpatient consultations are through general practitioners, but also through specialists. For example, pediatricians, obstetrician and gynecologists, orthopedics, general surgery, and nutrition and mental health consultations as well. We're providing 120 to 150 patients with emergency services through our ER daily. We're performing 20 major surgeries per day on average, and 9 to 10 deliveries, which also include C-sections. Since opening up in January, our field hospital has provided critical medical assistance to almost 30,000 patients. We have performed more than 600 major surgeries, and we have delivered more than 300 babies. Our major trauma load is blast or shrapnel injuries, but we also see gunshot wounds. The major surgeries that we perform are orthopedics in nature, which include external and internal fixations, damage control surgeries, emergency laparotomies, thoracotomies, skin grafts and flaps, as well as amputation. We are also helping patients with medevac in case there is a need for intensive care or long-term care. We have a long history in disaster and conflict areas, especially in resource-limited settings. And there are other challenges which are specific to this context as well. And we try to address those challenges through innovation. We've come up with some very innovative ways to manage the workload in the hospital. We have limitations in terms of communication equipment, in terms of supplies that do not reach the hospital. It's difficult getting supplies into Rafah at the moment, as you're sure. And we deal with them through different ways. For example, I'll just quote an example. We don't have comms equipment, we don't have pagers, we don't have communication equipment. It's a huge field site. It's more than 11,000 square meters. So what we do with mass trauma is we have designated people who, in case of emergency, they start whistling and shout trauma, trauma, trauma. And in each department, you have a designated person for that. And that's how we deal with trauma or mass casualties in these resource-limited settings. There are also challenges with insecurity. It is a field hospital with serving our patients in tents, which is not the best protection against shrapnel and gunfire. But we try to minimize that risk through our security measures, to making sure that the most vulnerable parts of the hospital are secured, and we try to make sure that our patients as well as staff, they are provided some degree of safety. I'll speak a bit about the overall conditions of people living in Rafah. It's a small border town which is south of Rafah, just bordering the Egypt border. And pre-war, it had a population of 70 to 100,000 people. Now we have more than 1 million people in this area. It's very overcrowded. It's because of the overcrowdedness and so many people not having good wash and nutrition facilities. It's very easy for infectious disease to spread over there. From health perspective, the needs are diverse. It's not just the trauma, there are also the non-communicable diseases that have not been addressed because of the lack of medications. We're seeing those patients with complications. There are also risks of infectious diseases. We don't have a very good surveillance system inside Rafah, but we're still reporting cases of measles, acute watery diarrhea, and jaundice, hepatitis cases inside Rafah. So those are the major immediate needs inside Rafah. And but we're trying our best to fulfill those needs through our health services inside Rafah. Thank you.
Thank you, Dr. Ali. Very grateful that you've made the time, and thank you for those prepared remarks. We'll be back to you momentarily. I want to turn now to Dr. Rick Peeperkorn from WHO for his thoughts. Rick, it's great to have you back again. You've been very generous to us. Thank you so much.
Thank you very much. Let me again first introduce myself. So Rick, my name is Rick Peeperkorn. I'm more than 3 years now the WHO representative for the occupied Palestinian territory. And also, let me say something about what WHO is doing in our, we have 3 teams actually, basically, a team in East Jerusalem, a team in Gaza, and a team in the West Bank. And I think from the start, we have gone, of course, through a lot over the last 3 years, and there's been many escalations, etc. And so we knew a little bit what and how. But this, of course, this crisis unfortunately beats everything, and with not only a regional impact, but a global impact. Is what you can call a mega crisis, and it changes also everything. So normally I went to Gaza to work with my team there every month. I was there a week, and so all the hospitals which have been shown, etc. I know them very well. I mean, we work with them, we support them with a strong trauma care program, supplies and equipment, health systems. We were even helping to establish an oncology, cancer hospital, you can think reproductive health, etc. The usual stuff. WHO does that and much more. So from when this crisis erupted, we were very quickly, I think, especially for WHO, we were super operational. We, like everyone, we lost our office and our warehouse in Gaza City in the north. Most of our staff who lived there had to move. We lost staff. All staff lost family members, friends, etc. And we opened straight away warehouses in the south to be as operational as possible. So that was the first thing, medical supplies in. And we started already in October that medical supplies in, trauma supplies in, essential medicines, etc. And to make sure, and I think against high risk, WHO was the first who really massively distributed its medical supplies all over Gaza, including to hospitals in the north, the well-known, the Shifa, Al-Ahli, Kamal Adwan, etc. And not only medical supplies, also fuel and sometimes food. Of course, in the overall scope, what was also described in a very good clip, too little and much more is needed. But that was our biggest focus at the moment, medical supplies, and trauma supplies, essential medicine. And the second part is, of course, EMTs. And I think that IMC is, of course, one of of an outstanding emergency medical team, and we work very closely with IMT. We support IMT also with supplies and also hopefully with the nutritional rehabilitation unit. I'll get back to that later. But there's many other EMTs now in, and how to coordinate them as good as possible, where can they be located, what is necessary, etc. The medevac is an issue we focus on, of course, together with UNRWA partners, other UN, UNICEF and other NGO and UN partners. Can we restore a little bit of primary healthcare? Outbreak prevention, I think my colleague mentioned something about it as well. And of course, malnutrition. I want to say something about that. And the last point is health information. I think it's a critical important function that we bring out factual information as good as possible. And because not only that we need factual information to make sure that our response is as targeted as possible, of course also for advocacy reasons. Now, I was in, during this mega crisis, I was in Gaza for 3 weeks, actually from early December, almost to Christmas, and then again in February, early February to late February. Next week, I'm again going in with some colleagues, again for 3 weeks from the 3rd of April, just to always work with the team, our team of national and international staff. I want to maybe raise a few general things. And one thing I want to say, and I think it's, by the way, everybody who has worked in Gaza, and I'm sure that my colleague from IMC will say the same. I was for 7.5 years in Afghanistan before this job. I've been for 25 years in Central and Southern Africa. I was part of in the 90s, early 90s, the whole HIV/AIDS epidemic. I saw the Rwandan refugees coming over Lake Kigali to northern Zambia, where we had to establish refugee camps, etc. And specifically, of course, in Afghanistan and the impact on HIV/AIDS in that when there were no ARVs, etc. So I've seen some really grim scenes in my life. And what you think, hey, we could and should have done much more to prevent or to assist. But what I've seen in Gaza and witnessed, and I think I hear this from so many humanitarian workers, is in that sense unparalleled. I mean, and it is shocking also to realize that Gaza, definitely the health system was not perfect, but it was a relatively okay functioning health system, which were producing indicators at par with its neighbors, actually better than its neighbors. And to see where it's now is quite, astounding. And we see, of course, the 2.2 Palestinians, Gazans, who are in this epic humanitarian catastrophe at the moment and facing inhumane conditions, widespread food insecurity. I think there is a looming, though, in our view, and I think the UN apart view, avoidable famine. We see the risk of starvation among the vulnerable, specifically under 5, etc., which has happened. Recent teams from WHO brought supplies from Kamal at 1, and that's also a task from WHO with PRCS to get patients from certain hospitals where they cannot get the care, especially in the northern Gaza, to the south or to medevac them outside. And we have brought quite a few patients now to IMC as well, as my colleague mentioned. Healthcare system is collapsing. At the moment, we talk of only 10 of 36 hospitals. I want to say something, but let's focus a bit on malnutrition. And again, I want to say there is no, you've probably seen the figures from the IPC report. It confirms what not only we ourselves, WHO, but many UN and other partners have been witnessing and reporting on a day-to-day basis over the last month. And it is quite surprising that, it seems there's too few people listen or help to act. So, and before this the hostilities and everything began, we talked about there was no malnutrition problem in Gaza. It was maybe you talked about 0.8, 0.7% of children who were acutely malnourished. And there was definitely a problem with some micronutrient deficiencies, iron deficiency in pregnant women, etc. But that was it. Now we talk in the northern governorates, the figure between 12.4 and 16.5% of the children are actually malnourished, acutely malnourished. And IPC warning for a risk of a famine, if this is not reversed by May in the north and by July, actually in June, July in the south. So the half of the population, 1.1, is experiencing catastrophic food insecurity. It's called IPC 5. And we've seen this enormous increase, quickly increase, even over the last couple of months. So in North Gaza, you talk about 1 in 3 children underage who is acutely malnourished. Completely, I would say, avoidable and hopefully also reversible. Now, what are we doing together with partners? So Kamal 1, the hospital in the north, it's the only pediatric hospital in the north. WHO supported the establishment of a nutrition stabilization center to treat children there, the SAM kits, etc., including in Al-Aqsa, and currently we are supporting Al-Aqsa al-Najjar, but also working with IMC actually to set up a stabilization center there. Many more are needed, and we need to expand them to actually all key hospitals in Gaza. And it will be complex because also the Gazan health workers were never used to this kind of acute malnutrition. When I was in Afghanistan, 10% of the children were acutely malnourished. There were a nutrition rehabilitation unit in every referral hospital. Here, we are not used to that. What is even more needed, and I think we need all partners for that, is to rapidly expand the so-called community management of acute malnutrition. With the nutrition cluster, UNICEF and partners, we hope to push this forward, and the place should be flooded with the so-called ready-to-use therapeutic foods, this RUTF, and that we hope to reverse this completely avoidable trend. My second, and maybe I have 3 points. My second point is about the health system functionality. And you saw the film and you heard the doctors speak and the health workers speak. So we talk about 10, 11 hospitals partially functional. What I think what we are so concerned, and we worked from this from the beginning, health services, hospitals, health facilities, health workers, they need to be protected. They need to protect that vital service, whatever is happening, they need to be protected. And we've raised this constantly and from the start. And we had hopes that in the last month of this conflict, of this crisis, there were more voices, and they said, yes, health vital service need to be protected. And we witnessed, lesser health service being less affected. Fortunately, over the last couple of weeks, we've seen that the Shifa, which was, as we know, was hardly functional a couple of months ago, that through support, first of all, the incredible health workers, a lot of them volunteers, support WHO and part supplies and equipment, etc. It was again a partly functional hospital. At least the first, it was again actually the last, just 2 weeks ago, it was functioning again as the trauma center of the north. Not the third level, I would say first level hospital, but it was getting patients, it was expanding, etc., dialysis, etc. Now, what we've seen over the last week, again, at the moment, the hospital is not functional. So it goes from functional to barely functional, non-functional, and then we build it up again, we revive it, and now again, non-functional. Shifa is absolutely needed in the north. Actually, it's needed for all of Gaza. WHO tried to assist. We were even invited to assist last Thursday, and today, unfortunately, our missions were refused. And we were going to bring in fuel and also, of course, do an assessment. The same, Nasser Medical Complex. I discussed it last time. It was also in the clip. The second time I was in Gaza, we visited that hospital twice. We were not allowed in to do an assessment. Then my team was, finally, we did a lot of patients, we call it transfer, medevac to hospitals in the south and Al-Aqsa, including IMC, by the way. And currently that hospital is not non-functional. This was what I would say the Shiva of the South. It had all the specializations. It's absolutely needed. I mean, field hospitals like IMC are incredibly important, but my colleague will confirm you cannot run health services with a number of field hospitals. You need to build on the existing health infrastructure in the health system, which is still there. The last hospital, Alamal, the PRCS hospital, you saw it in the news, etc. Again, so we are deeply concerned about that, including we see a huge number of health workers being detained, sometimes completely for their families and organizations, unclear about their whereabouts. And this is what my team tell me, and I heard it even when last time, is a lot of health workers, specifically in the north, but all over, they're scared. They're scared to operate. They're scared to operate because see what happens in Shifa, see what happens in Nasser, see what happened in Alamal, see what happens in this hospital. And they are scared, of course, to be, if there would be siege, that they would be arrested and detained, etc. And we already saw, I mean, Gaza used to have 25,000 health workers, 25,000, 11,000 nurses, midwives, 5,000 to 6,000 medical doctors, 500 to 600 medical specialists. Gazans can do a lot themselves. We estimate that at the moment, maybe 20 or 30% of them is operational. There's a lot of volunteers, and we want to make sure that they can do their work with all our partners. Now, the medevac, we discussed that a few times. I still think we consistently need to raise it in this program. We have estimated that 8,000 plus cases needs referral. 26% or even more of what I would say are regular patients. 26%, for example, are cancer cases. 43% activates war and war-related injuries. All the horrible trauma, the spinal injuries, the amputees, a lot of the reconstructive surgery which is needed, which cannot take place now in Gaza. Kidney dialysis, etc. And it's currently, there's an ad hoc system operational. We only have seen, since the start of this crisis, 2,630 patients referred. That's way too little. Egypt says they're ready. Other countries reached out to assist and said, we have to make this work. WHO came a number of times with a proposal how to do this in an organized and a transparent way, and we have to push that. Medical evacuation, it will, first of all, it's a right for the patient to get a treatment they are able to get, but secondly, it will also help to relieve a completely overloaded and undercapacitated health system on its knees. Let me stop there as an introduction. Thank you very much.
Thank you. Thank you. Before we turn to my colleague, Michelle Strucke, who's the director of the Humanitarian Agenda, I just want to invite Dr. Ali to respond to anything that's come forward in Dr. Pieperkorn's remarks. Ali?
I echo Dr. Pieperkorn's thoughts on what he mentioned. Yes, there is a need, especially in terms of field hospitals. Those are good solutions to augment the health system, but it's only a temporary solution. There is a lot of work that needs to be done in rebuilding the existing hospital capacity. Of course, healthcare infrastructure and healthcare workers, they should not be targeted. It's an essential service. You have to maintain security for healthcare infrastructure and healthcare workers in danger, in violent situations, or a threat of violence to them will be very difficult to the consequences of that on the health system would be immense and are immense in Gaza. I also echo his thoughts on malnutrition. There is a malnutrition crisis going on in Gaza at the moment, and it can reach catastrophic levels, especially in the north. It's creeping down south as well. But essentially, the humanitarian space that has to increase, it's very narrow in terms of supplies, in terms of security. It's difficult for us to go into the community and do community interventions that are much needed because of the insecurity. These are things that we need to address to make sure that we can save lives inside Gaza. Over.
Thank you. I want to invite my colleague and friend, dear friend here, Michelle Strucke, to offer some thoughts.
Thank you so much. And thank you, Dr. Ali and Dr. Pieperkorn, for these remarks. Watching this video today really brought me back to the work that I did with the Syrian American Medical Society, working with organizations like IMC in field hospitals in Syria. I did that remotely from DC, but just watching that, I thought that there were some themes to draw out that our colleagues here have raised today. In the video, you can see this level of destruction. You can see how many ambulances were damaged and affected. Each of those would have been helping, countless patients be able to get treatment. We've seen the WHO has said that 104 ambulances have already been affected by health attacks, 54 sustained damage in Gaza, and this is a very dangerous operation. So the colleagues that are, providing healthcare in this environment, local and international, are under great risk, as more than 160 aid workers have been killed in the conflict, and 118 health workers have been detained and arrested. So I was definitely contemplating how difficult that situation is. At the same time, in the video, while we see the physical destruction, just hearing, about the incredible capabilities that have been stood up, I wanted to repeat the point that these kinds of field hospitals have lots of limitations. They're not referral facilities. They're not hospitals that can handle the gross amount of needs that we see in Gaza. So that the fact that the existing health infrastructure is so devastated continues to be a tragedy. One of the things that I was thinking about as well is that aid workers, health workers, they're not superhuman. We heard from colleagues how aid workers and the health workers are themselves facing the same things that others are facing: lack of electricity for 165 days, lack of healthcare for themselves and their families. They're facing themselves food insecurity. So to have to be put in a position as a health worker to provide care to people when you and your own family are not taken care of is extremely stressful. So I wanted to share those things. In addition, one of the biggest tragedies, I think, of humanitarians is that when you're watching a man-made crisis happen, it's as if you can see preventable deaths in slow motion. I've heard the kind of looming famine described as a massacre in slow motion. This idea that you can look at all the numbers that our colleagues are citing, incredible, data that they're gathering despite great conditions, and can see that many more lives are going to be lost. And all of this, knowing that it's preventable, that if more border crossings were open, if hospitals and medical workers were able to get the supplies that they should be able to get, if trucks were not being stopped and having to be sent back because they can't make the amount of time that they're given to get supplies in, if warehouses were able to be accessed, these are the kinds of human tragedies that we're watching happen and are sadly predictable. And that, I think, is one of the difficulties of humanitarian assistance, that in a situation where there are real, tangible, logistical things that could happen, policy choices that could be made to allow more aid inside and not to obstruct it, that itself leads to these kinds of crises. So to share that, this preventable nature, I think, is quite tragic. As we're watching the specter of a potential Rafah invasion, ground incursion, I want to mention to those who are following this conflict, know that bombardment is still happening. The active hostilities are still happening, and including in areas that people are, like Rafah, where people are sheltering in great numbers. So as there's a specter of this potential ground invasion, the question of how to ensure that civilians are out of harm's way, to ensure that healthcare facilities are protected so that they're not subject to attacks. All of these are, I think, the most important questions that DC policymakers, I know this week, are thinking about as they receive Israeli counterparts that are coming to speak to them. The last point that I'll mention is just that when we watch the video, another, I think, important thing to raise is just how difficult the situation is when doctors are working to provide care without adequate medical treatments to be able to ease the suffering of patients. The video didn't show that, kind of sounds that I'm sure people are hearing as it was edited, but it's a extremely difficult kind of human situation as a person of conscience to watch this unfold and know that people are suffering the way they are.
Thank you, Michelle. Let's come back to Rick and then to Zawar for your thoughts on what we've just heard here. Over to you, Rick.
Well, I want to respond once to my colleague Ali from the IMC and then to Michelle. So I think
Yes.
so. I visited also IMC and I saw for myself actually very unfortunate that it happened. So on the moment we visited, there were 2 severe trauma patients came in, were rushed inside. I said one had to be referred to the European Gaza hospital and the other one also stabilized, etc. But I witnessed how professional they worked, and I think it's definitely, and for me it was, and maybe you guys might have worked with many, it was one of the more model field hospital, and professional, well structured, well laid out, etc. Well, so we were really, I mean, they used a lot of supplies we as WHO also provided, and so for me, it's definitely there's need for a few more of these hospitals on strategic locations. But I think what I try to raise, and I think what Ali confirmed, it cannot replace the existing health system. We need to make sure that the existing health system is protected, that it is strengthened, that it goes back, it's on its knees, that it goes back on its feet, etc. And that we link EMTs to some of those existing referral hospitals and then hopefully expand the bed capacity, etc. That's what we should do. And I think what Michelle made a couple of points on I think first you made this point on the incursion and if this would happen. So the last time I was in Gaza, we had discussions on this between a couple of hospitals in Rafah, including IMC. And if there would be an incursion in Rafah, most likely IMC would, and maybe Ali wants to say something about it, they would probably have to shift as well to back up places somewhere else. But it also, what is I think extremely worrisome, there's a hospital, Al-Najjar hospital, which was, because Rafah was, I know Rafah is a sleepy little town of less than 200,000 people, and now it's 1.5 million. And Al-Najjar hospital was a relatively small hospital. It was actually, I think it was originally an expanded primary healthcare clinic, level 4. And now it is functioning as a kind of referral hospital. But already then, the director and team were making plans in case there would be an incursion, because it would most likely, they would be also on that line. And they would go from partly functional, fully functional, very quickly to barely functional, and what to do and where to go. So they were making plans already where, and could they shift something to Al-Aqsa in the middle area and this and that. Plans like that. Plans which you do not want to make and which you should not want to make. The other pragmatic thing is, at the moment, Al-Najjar, including IMC, and they refer, and some of the critical patients refer to the European Gaza hospital, because there they have the diagnostic capacity. Now, that line would be also blocked if there would be an incursion. So all those things where plans are made, what could we then still do and how could we do that? You don't want to make these plans, and those plans should also not be necessary. And I want to raise that very quickly. And the point of course, if we would see more shifts and internal migration of already displaced people, so where would they go? They will have to go to the coast, to the middle area, which is also completely overcrowded. And I think it was, I believe, Ali who mentioned on the on what we already see now, the diseases, and we've raised it a couple of times, acute respiratory infections, etc., on more than 500,000 since the start. Diarrhea, 20 times as much as normal, and almost 300,000 cases. Jaundice, 15,000. So it all reflects the overcrowding and the lack of water and sanitation and everything around there. And that would, of course, only be amplified if you get more and more people on the move. So that's, of course, this constant cry out for a sustained ceasefire, and that we can start thinking about early recovery again. And I agree with Ali. Everywhere when I travel to the north, but also in Khan Yunis and even in Rafah, especially Khan Yunis and the north, the destruction is immense. I've never witnessed something like that in my life. So there will be a need to such a large scale early recovery, rehabilitation, and reconstruction, etc. And of course, at WHO, we will definitely focus on everything related to health. But as we know, so much more is needed. I hope member states as well realize that and start thinking along those lines. And the last point I want to make, I think Michelle made it. What is needed? I mean, and how do we flood the place with food and specific foods? And also, by the way, how do we restore some of the food production? Gaza had a lot of fishery. Gaza had a lot of poultry, eggs, and a lot of vegetable and fruits. That is all. Most all of it is destroyed or is not functional again. That should be made functional again. I mean, that's the start. And we hear and we see a lot in the news about alternatives for entry in Gaza, the maritime corridor, the so-called pier, the airdrops, etc. Well, we are open for everything. I mean, the more the better. But there is no alternative for land routes. Land routes, and if the land routes would properly function through Rafah, through Jordan, but also the use of, for example, the Ashdod port, which is 20 kilometers from Gaza, which was always used for Gaza, and another entry in the north of Gaza, clearance of these roads, and we can see it can happen very quickly. There's a whole new road constructed from east to west, so clearance of these roads, etc., so that you can have 15 humanitarian convoys per day to the north, and that you have constant humanitarian convoys in the south. A lot of this can be addressed. So this is where it cannot be an alternative. There's no alternative for proper land routes. I just want to make that point as well. Over to you, Steve.
Thank you, Rick. Zawar, maybe you could say a few words about contingency planning. I mean, here in Washington, this week we have visiting senior-level, high-ranking delegations from the Israeli government. There's an active debate around will there be a siege or not? What conditions should be insisted upon in terms of respect of civilian safety and well-being in this context? How do we make judgments around that? We had our funding bill passed, which carries the government through October, which includes a provision banning any additional U.S. funding for the next 12 months to UNRWA, which was a setback for many of us who have argued that UNRWA remains absolutely essential here. Tell me, Zawar, how is the team, the IMC team, dealing with these possible contingencies as you think about this field hospital and what may lie ahead?
We constantly analyze the different factors that come into this analysis matrix, and we're constantly thinking about different ways to ensure that in case of an invasion of Rafah, in case of any other eventuality, we're able to serve our patients. As Rick mentioned, there is a budding health system in Rafah. This is more than 1 million people, and the health system includes the healthcare providers as well as the patients. They've gotten used to a certain health system. There is some, with a lot of effort from WHO, from other actors within Rafah, there is somewhat coordination between these different actors. Patients know where to go, how to access health. To a certain degree, they can access health as well. But if an invasion happens, and there, of course, we can come up with contingency plans, but it doesn't really, it wouldn't ever, replace the existing health system inside Rafah. If an invasion happens, we're looking at it from, and we've discussed this from a healthcare provider perspective, but from the patient's perspective, I can tell you that patients who used to go to, for example, to the EGL, to the European Gaza hospital, once there were hostilities near the hospital, they had some hesitancy in going to that hospital. And a lot of those patients started coming to us. It was the same case with ambulance drivers as well. So once there are hostilities in an area, or healthcare infrastructure is damaged during an invasion of Rafah, from the patient's perspective, it would be very difficult to go back to those hospitals. I would say that there was a preference from the patient's side to come to us as well, because we were relatively unharmed during this phase of war. So we have to look at it from that perspective. A patient-centered approach to health system is also important. And if these interlinkages between different actors in Rafah who are providing health services and actors who are coordinating these services, if this stops, we have contingency plans. We might have to shift our hospitals in those cases, but it would be very difficult to replace the trust that the people have in these health services. That is where I'll stop on that. Thanks.
Are you both operating on the assumption that in the next 4 to 8 weeks we will see a rapidly escalating problem of famine and starvation, regardless of what scenario we see, that this is, when I read the IPC report that just came out, it was pretty stark, and it was exceptionally detailed in the modeling and the data that was used. I just wanted to ask both of you, you're consumers and contributors to this work. You're monitoring the conditions of the populations served, but you have to be thinking ahead about what the next phase is going to look like. How does this specter of famine and starvation figure in your thinking? Rick?
Sorry, I find it a difficult one. So when I read the report and we contributed to these, some of my colleagues contributed to it and with the data, etc. And of course we analyze. Of course we discuss this in a wider group. And as WHO, where we work very much at the hospital, health facility level and support, and of course in the community level, with the health cluster and with the nutrition cluster, we focus. But then you're already too late. You're already on the receiving end. You're establishing therapeutic feeding centers or stabilization centers, as they call. We should do that, and as quickly as possible and more. But indeed, you want to prevent actually that they are really going to be used on a massive scale. I still have some, and although my hopes have been thwarted in the past as well, I still have some hopes that the world has waken up. The pressure should be that the place, specifically in the north, but also in the south, should be flooded. Not only with food, because a lot of the food, of course, is low nutritional value, but with diversified foods, including what is said this community malnutrition centers with RUTF, etc., and more diverse. And that's the only thing. What at the moment, how that can happen, if the land routes are optimally used, and that's not only to Gaza, but specifically within Gaza, that this is happening much more, and I think early March I had a bit of hope that even from WHO, some of our missions were going again to the north. In January and February, we really struggled. We had a lot of missions denied, delayed, cancelled for whatever reasons. And we pushed and pulled and this and that. And then WHO is a relatively small blow. Food, you talk about bulk supplies, you talk about convoys, you talk about much more. And for me, I think this is possible. So I still have some vague hope that the land routes will be optimally used, that there will be a more workable deconfliction mechanism for when you organize those missions, and that's the north, but also the south. And you need to do that, and of course, in a carefully planned way. And some of the UN agencies are doing very well on that. If it is UNRWA or WFP, etc., they know how to do that. You need to discuss with the community leaders. You need to use your influencers, etc., to make sure. We've seen a lot of breakdown in law and order over the last months. Is that surprising? No, not at all. I mean, not at all. People are desperate. There's a lot of things going on. So you have to take that away, organize that better, make sure that these land routes are fully operational. And I still have a vague hope that this trend can be reversed. So that's, that we, however, we should be prepared. And this is where I'm now pushing my team, and we have mid-sized teams. So we do this with all partners, including all EMTs, like of course IMC, etc., that we indeed establish stabilization or nutritional rehabilitation unit, whatever you call it, in all key hospitals. Make sure supplies are there. Make sure staff are trained and know how to operate that. More importantly, these community centers and flood the place. I still have vague hopes that I hope and expect that we can reverse these trends.
Thank you. I think that, Rick, these very concrete priorities are quite important now to convey to a Washington audience in particular, where there is this active debate going on this week, and to hear those messages about what needs to happen in what level of prioritization in order to avoid the worst possible outcomes. Zawar, did you want to add anything to what Rick said? And then we're going to come to Michelle for the closing segment of our program.
So I would say I'm not as hopeful as Rick is when it comes to the nutrition intervention, because the main part of that is going into the community. Currently in Gaza, I don't see the conditions where it is easy for aid workers to go into the community and safely carry out these nutrition activities. There is, of course, a bottleneck at Rafah, the land routes that Rick is talking about. But then once you cross Rafah, then this is over 2 million people, and reaching all of them in these conditions, it's very difficult. We have to prepare for a scenario where there is a proper malnutrition crisis, and that is what we're coordinating with, as Rick said, setting up stabilization centers. But that is a reactive step. We need to be able to go into the community and avert this disaster. Thanks.
Thank you. Michelle?
I believe what we're hearing, which I think is really important, as you said, for the Washington audience, is that a lot of these constraints that would cause our humanitarian colleagues to be able to save lives are access constraints. They're things that policymakers can make decisions to get around. And it's, I think, extremely important to emphasize that the heroic actions and ingenious actions of coming up with stopgap measures like the airdrops and like the maritime corridor are important, but they, again, are no replacement for land routes. They're no replacement for supplies getting in and for access within Gaza to be facilitated so that people are able to bring the badly needed aid to people in need right now. I think it's really important as well to emphasize that this is not someone else's responsibility. The Israeli government has a responsibility to facilitate and provide that humanitarian aid. As much as international organizations, nonprofit organizations play a critical role, They are not a replacement, as we mentioned, for Gaza's actual infrastructure for them to be able to be self-reliant, and then for authorities and parties that are engaged in this conflict to allow humanitarian aid in. And on that, too, it's obviously extremely important that Hamas stops using these illegal tactics of putting people, embedding in the population and as well playing a huge role in causing these difficulties. That being said, in many conflicts around the world, we have parties to the conflict that don't play by the rules. That doesn't take away any obligation to provide that humanitarian aid and make sure that it gets in. So again, access continues to be such an important issue, and choices that are made, like continuing to have electricity cut off, continue to hinder access as well, because aid workers are not able to effectively communicate with one another. I was really shocked by hearing that, having a person that had to just shout trauma because the hospitals are not able to have communications inside. That's something that should stay with all of us. It's something that should not be happening in any humanitarian situation, particularly now for almost 6 months. So I do hope that policymakers, again, consider these larger, sustainable actions that can try to prevent that man-made tragedy that we're seeing unfold. Because while we can't undo the many lives that have been lost and limbs that have been lost and family members, there are still people that could be saved.
Thank you, Michelle. We're getting towards the end of our hour here. I want to come back to Dr. Zawar Ali and Dr. Rick Pieperkorn for their closing thoughts. I guess the question I would pose to you, we've heard a lot of very specific and concrete suggestions around those things that absolutely need to happen in order to change this picture and change this dynamic. So we've got a lot of that already. This has been a very rich and very valuable conversation. Is there some top-line message that you wish to convey in closing here? This is a big week of debate and discussion here in Washington about what happens next. And this is an opportunity really to convey what each of you feel is most important in communicating to policymakers who may or may not fully grasp what's going on the ground. So I'm going to start with you, Dr. Ali. What would be your mainline message to close with?
We need to ensure that supplies go into Gaza so for us to be, or for all health actors to be able to provide services inside Gaza. 2, healthcare service delivery points, healthcare infrastructure in general needs to be protected. And 3, we should have the ability to increase these health service delivery points because the needs are massive. So supplies, protection of healthcare infrastructure, and the ability to expand healthcare in Gaza at the moment.
Thank you. Thank you, Zawar. Rick?
I've got so much more to add. I think Ali is very clear. I think also Michelle was very clear in her closing statement. We discussed the whole issue, and unfortunately, it comes back to access, proper access all the time, and proper access to, but specifically within Gaza, and using indeed these land routes in a much more effective and efficient way, in a way that it is safe for humanitarian convoys to move and to do their things, which they should do, and move not just 1 or 2 a day, no, tens a day. I mean, like we flood the place. I also think what I heard that, because if you can get proper access and it becomes more safe, even if there's an ongoing war, there should be humanitarian corridors. You should be able to move and do your work then in a relatively safe environment. That's the only way that you can create and get back to links with the communities. At the moment when we do missions to hospitals, we know the hospitals and hospital director, we know some of the hospital staff, medical specialists, etc. Although of course they change, etc. We know that, but that's the only ones you talk to. I think Ali, made one good point that you need to gain the trust of the community. At the moment, the Gazans don't trust anyone. They lost faith in I would say, and I'm talking about the Gaza population, people on the ground. They lost faith in a lot of what's happening in the world and how they are supported. And I think when you make the work of humanitarian partners, when you do not facilitate, but you make it more difficult, etc., you create even more issues and more unnecessary problems. The last point, I think you said on that, I think, yes, we should also one message with regard to malnutrition, incursion, and this and that. In a way, we have to prepare for the wars, and we should prepare for that as humanitarian partners as good as possible. And that is complex, because Ali will tell you as well, there is, in my view, still very few humanitarian partners actually operational in Gaza. It's very difficult to be operational in Gaza. We didn't even discuss that. I mean, like, your own national team, to get your own national team operational, and who have been traumatized and have been shifted the same like any other Gazas, 6-7 times, who lost family members. We lost our colleague. Everyone has a story. Everyone has a story. And to get them back, and it's amazing that so many are still operational and focused, but to rebuild that trust, you finally the Gazans will have to recreate, their society and their work. Palestinians need to do that, and there's a lot of capacity there. So we need to somehow rebuild that trust and be able to reach out to community leaders and do our thing. So prepare for the wars, but I hope the wars in my view is absolutely not needed. Food and a malnutrition crisis, etc., is looming, and a famine is looming, but it can be prevented. Trends can be reversed, but we have to unfortunately prepare for the wars. Let me close there.
Thank you. Dr. Zawar Ali, Dr. Rick Pieperkorn, we're very grateful to each of you for your courage and your commitment and your leadership in this extraordinarily difficult situation, and to the organizations that you work for, IMC, International Medical Corps, and World Health Organization. I want to also thank my colleague Michelle Strucke for joining with us here in putting this broadcast series together. As we've discussed, this is a big week for debate over what comes next. And these opinions, these thoughts, these insights are going to be very, very important in trying to shape those outcomes. Thank you to all of our audience who've joined us for this hour. We're adjourned. Thank you.